Joanne, is your intake form for peds on the Jane templates like viewable by the public?
Oh, no, I haven't done that. I could. It's in
That
the
would be
birth and
super helpful.
mechanisms of injury course.
Is it? Okay.
Did you take that course?
I did, yeah.
Yeah, I wanted to put everything concise in one spot because it's annoying to go look everything up yourself. And then
Okay.
comments from Dr. Dustin Costasque. He's an OBGYN. He commented,
Hmm.
I had him on a Zoom and I added blurbs of what he was saying at the end of all the chapters. That's a good course. Like if you're putting off learning about like a little bit more about birth, you may have given birth, it doesn't matter, you need to know a few other things. Just a good easy way to do it. So hey, let's just look at some pictures. I'm just going to go through, make it big. Let's make it big. So this is me inhibiting this little guy's lumbars and trying to get some farts out so I can start working. Trust me, it can save your treatment. Just take the time, try to get some farts out. Don't panic, just let it happen. And again, worst case scenario, no air moves and they're still crying to say, Mom, we got to get them on the boob. And then I'm going to try to treat when he's suckling. Here, I'm just balancing the sacrum and trying to bring it up to clear a little bit. You'll see in that reel on Instagram how to get the tension off from umbilical area to the falciform ligament. I've done it so many times, and liver. I've done it so many times I don't have to expose the skin. So I'm doing that there. You want to take tension off the abdominal wall and try to approximate the umbilical area with the liver. You can have a hand around the umbilical area or not. But if I was just starting out doing this, I would keep my hand on the umbilical area. This little honey, I'm just treating the right side of the pelvic floor. So you do have to check the diaper, make sure there's no poop in it, and try to get your thumb real close to the ischial tuberosity. Most babies have a tilt in their pelvis. You'll see the pattern, and it has the right innominate is very anterior, and the left one is super posterior. And that doesn't clear in one treatment. It takes a while for that to unwind. That's from that embryological, growth, but a nice way to get something unhitched in there because moving the innominates won't work. And you have to be careful because their sacrums are almost all cartilage when they're babies, and the coxofemoral joints are they're tender. It's cartilage in there and there's no femoral head yet. So use soft tissue to release what you're doing and just check. That's my little hint. Check the right kind of ischial tuberosity just in the pelvic floor there. Explain where your thumb is. Just say it's really near the hamstring where they sit on the sit bone, and I'm just trying to release in there. That's the best way to get that darn sacral tilt out, in my opinion. This is the positioning for car seat treatment. So I'm lucky my table can go up and down so I can get the perfect height. So basically, that car seat has to go low. It's on your table, it's got to go low. So look at my arms, elbows in, I'm secure and I'm feeling. I'm not concentrating on holding my arms out. I can concentrate on my palpation right there. And then this is just obviously from the front. And I can move around and do the cheekbones or the ethmoid area nasal bones if I want. Here's a few hand holds on babies. I do this sphenoid hold because you don't want to use too much direct fingertip on babies. It's too pointed. You need to spread out your touch on the skull because it's so tiny. Just remembering to don't let them cry anything out. Just give them a mom. That's the best way you're going to get changes. Take the time to keep them calm and happy. Here's a little cranial base hold in supine. And I try not to lift their head too high because their necks are so short and I don't want to put the dura on tension. This is how I would hold the lateral cranial base, get those temporal bones to relax, and near the sides of the C1, just see what's going on in there. This is the thorax treatment. My posture here, I will admit, it's terrible, but I was doing home visits at this time, and this is not an adjustable table, so I did my best. But this is perfect because you can feel everything. Lots of burps come out. If you see a baby that you're treating in supine and they start to grunt, sit them up like this. I bet you burp comes out. Then they're happy again. But getting back to treatment, yeah, you can side bend, you can feel all the ribs, you can bring one arm up and tilt them over. They love it. They can see mom, their head is supported on your shoulder. That's just another one. You can, a little different angle there. Happy, happy. This is how it would hold like parietal bones. This is, this would be more pertaining to like a cranial course, or maybe we'll do a cranial session sometime. Just really gentle. I love this. Cradle their sacrum in your hand and check for rotational restrictions through their body and see if you can rotate the hips and shoulders opposite in each direction. And you can create a little distraction or compress back up. See what baby prefers. Gassy babies love this. Balance the tummy in the back. Just see what can happen there. Maybe they might start to toot. That's the inhibition picture again. I'm just using my fingertips to see where it's hard. You can treat the back of the cranium inside lying too. Some babies love it inside lying. Most babies do, some do not, and that's okay. And look, baby was fussing, so I picked her up and I hadn't really done much assessing yet, so I did it while we were walking around the room. Be flexible. Don't let them scare you. They just want love and they just want, to be held and to be entertained. Yep, pick them up, keep working. See them doing the hip there. This is a good fascial neck stretch. Just giving her a hug. I'm keeping her happy, but I'm still working, right? I'm doing a little bit of a OA side bend opening right there. See that? Keeping the soother in, stabilizing, multitasking. That's what you have to do. A little nasal decompression. Some babies don't mind it. The young ones don't care if your finger is there. Now, if they're really, really young and they start feeling agitated, they could be tender there. So just switch your hold, do something else. Again, love that hold. It helps them decompress if you want to do that. And if you take the time, go super, super slow and add some flexion by bringing their little butt away from your body, you can pick up where a spinal restriction is. So the further out you can bring their butt away from your body, the higher up you are in their spine. And if they kind of snap back against you, that's where the restriction is trying to show you it is. That's what I'm doing there. So head, maintain contact of baby's head on your sternum. And I'm a little bent over because I'm kind of bouncing the baby in between to give her some calming, lulling. And I'm trying to take her pelvis away from me so I can see if there's a restriction somewhere in her spine. Because she just didn't want to lie on her back for me that day. This is twins, by the way. Had a little photo session with twins, very helpful. Reassessing. So we just saw that picture already. Here's some prone. Some babies love it on their tummies, some don't, but it's worth putting them on their tummy real quick just to check for some restrictions in their little TVPs. They don't extend too much, but you might feel that something is very, very rigid when you try to put a little bit of a spring in there and just focus in on that. This is what I love to set them up in. Something rolled up. They feel like they're in a little taco and they feel secure and they fall asleep sometimes. Here's the little temporal bone decompression. So cute. That I'm just generally balancing the dura because the dura runs all the way to S2, and that's going to control the release of cranial bone overlaps. Here's a little zygoma lift. She didn't seem to mind it. She's actually awake for that. She didn't mind it. Checking out the ethmoid area or just nasals, does anything feel tight in there, left or right or midline? You can balance things, just bring it all together and make there be a balanced field between mandible, parietal bone, and temporal bone and the posterior cranial base. Works really, really good. So love this picture. And I'm just trying to indicate and show you elbows in against your body so you can concentrate on the palpation and not on what your own body is doing. This is wrong. This is a little bit wrong. Even though I'm resting my elbows because this table's not adjustable, I've got a kink in my wrists. So if you can see that black swoopy line, it's trying to indicate there's a kink in my wrists and I'm not going to palpate properly. So just, even though you're resting your arm somewhere, make sure the angle through to your hands is good. Okay, so this is an old Instagram post picture, but this is me doing some assessing for around the world for the soft tissues of the lips and the buccals, which are cheeks. Sometimes it's very, very tight on a baby and the skin will blanch and it needs to be massaged very gently. And you can do that or teach the parents to do it at home. give baby breaks so they can swallow saliva and so that they can move their tongue around. So mom's not breastfeeding here, but mom could be breastfeeding here. I would come in from the side, be ready to do lots of standing or get a different chair so that you can sit beside a mom and just start to feel everything. You know, baby's fussing, they can be held by mom, and you can start working. And I'm just gonna scrub this a little bit. The head will start to move, and as things are releasing, just follow it. You can move your hands around. Then I just want to show you how I use the blanket. So remember how I like roll up each side? When they're in side lying, this is very helpful because number one, it'll keep them in side lying, and then I can keep tilting things. Yeah, now the baby's starting to fall asleep because they're like a little baby taco, little enchilada, and then I can feel down the spine. Sneak your hand down the blanket, bring it up to the skull, pop that soother back in, or ask the parent to do it for you. I'm feeling the abdomen because baby fell asleep again. And then I'm gonna do some intraoral assessment and treatment. So have a size small or medium glove. If your hand is small, get small gloves. This is a whole mystery is debunked. I've figured it all out, made very easy flow chart. If you don't know how to do intraoral and you're scared to do intraoral, there are easy ways to do it that take the stress out of it and the mystery out of it. So you know what you're feeling. So you know, like, what am I feeling for? What am I doing with all of this information? So I'm doing a little bit around the world, and I had assessed the hard palate, and that right at the end there, I assessed latch. So let me just get to some latch stuff. This baby's passed out completely. You're going to see the blanching. Hold on, let me get to hold on. She turned. See, she turned away. I used my blanket. Got her back where I need her. Okay, I don't know if you can see. I'll back it up a bit. Watch how she blanches through her cheek.
I'm going to check the bottom lip just because
what, like the fold in her, it goes white. It goes white. See how it's white around her lip and purple?
I'm just going to let
that's tightness. So you wanna clear those easily, gently. She's crying because she's trying to sleep. That does not hurt her at all. It's very gentle. Then testing latch at the end, and then I go under the tongue eventually, I think. Sorry, I'm gonna scrub because many babies can't latch well because the sublingual area is way too tight fascially. You can barely get your pinky finger in there. I use my pinky because it's my smallest finger. I give them a break in between massaging each side, very gentle. Sometimes I don't even move my finger. They're so busy trying to move their tongue around to get me out. That's what's doing the treatment part of it. And then doing that soft tissue work around the mouth changes the neurology in the mouth, obviously fascially too, and can get you in the door to deeper latch palms. This little guy has hypotonic tongue.
How long did it take to
problem? Look at that saliva. Look at his tongue, no tone. Even his mouth looks floppy. Hypogag reflex. I'm testing to see if he'll push against my finger with his tongue. Yeah. That was a tough case. That was really tough. See how he can barely push against my finger. He's chewing instead. You'll see that as a compensation if parents, moms usually say that the baby is chewing instead of sucking and it hurts. They're compensating and trying to get milk out by gnashing instead of using the tongue to scoop under the nipple areola or your finger if you're motion testing and testing the suckle. You'll feel that the tongue doesn't scoop your finger and they're using the wrong muscles to get the milk. I took this picture just last night. He's got a recessed chin. There are 0 lesions in this kid, 0 structural restrictions. The only problem is his hyoid bone and mylohyoid, geniohyoid muscles down under the chin, so floor of mouth, and his tongue would not rise up and lift up. I had to work fascial and muscular just around his mandible. I've actually never seen anything like it. His sphenoid was fine. It wasn't that his mandible was tight from like a sphenoid issue or OA. It was very local. It's very interesting case. I thought that was cool, but I'm hoping, so I took a picture because I want to see that mandible come forward. I also asked parents too, like, hey mom, did you have a small jaw? Like, did you have an underbite? And she said, yes, she needed surgery on it to have it lengthened and brought forward, a very intense surgery. So when you see some things, ask the parents, hey, how did you look as a baby? Hey, does your husband have like more of like a higher, like elongated head? Or who does baby look like in the baby pictures? Like you as a baby or dad as a baby? And find out, is some of this like just genetic in the way their head is shaped or the way their chin is? I don't know. I didn't get to treat that mother when she was a baby, but would some of what I'm doing for him, their son, would that have helped her? I don't know. I'm going to try it, right? So I'll take a picture in a little while. This little girl here, so she's one of the case studies, as is the sloppy tongue little guy. There's 7 different case studies, I think, in the intraoral course. This is that, it looks like a good latch, but it's a poor latch. This looks like she's sucking good, but she actually isn't. So for beginners, I would, in the course, I tell you it's a good latch because she's doing well. But later on in a tutorial at the end of the course that I added as like an extra hour of learning, and you get credit for that for your learning credits. You learn why this isn't actually the best latch. Now it's working for her. It's not terrible, but she's compensating. And I explain why in that tutorial at the end of the intraoral course. But for beginners, this is not a bad latch. This is just me doing some sublingual work. You can massage, you can let them poke their tongue around, take your finger out, especially if they're slobbering like that, give them a break, praise them, smile at them, and then, you know, coo. They'll coo a little bit. And this is an example of a good suck, swallow, breathe.
Yeah, like her tongue comes down around my finger. See how the bottom of her throat goes down and up, down and up. And it doesn't look like it's tight from the side, like the cheeks are moving.
See that? Everything's moving.
It's fantastic.
That throat has to look
really
like it's
good,
filling up.
really
it can't look tight in the TMJs.
Perfect.
Stop to take a, they often
and
do
the
that. They stop to take a break.
Tight.
This is
that motion that's important.
The lips don't look like
like
the little miss. See how this baby's lips are relaxed? This baby here, holding on for dear life with the lips. That's how she's compensating. She's using more of her lips. It's not the end of the world, but it could be better. And then this is breastfeeding, what looks good. Because a baby sucks on your finger a little bit different. So look at that fullness. TMJ doesn't look tight near the ears. That much cheeks are filling. There's no clicking. You have to listen too. No clicking. That's important. And there's no little air gaps at the corners of the mouth. I just thought I'd throw this on because look how broad it is at the base. That's what happens to the rib cage when there's that much air in there. Look at the air in this x-ray. Sorry, it's blurry, but that's very uncomfortable. This is why babies need diaphragm work, you know, and a good thoracic and abdominal pressure gradient. I just thought, you know, I'd throw this picture of this is truly torticollis when the muscle has not grown the right length. Rarely, but sometimes babies get surgery on that. Some things that you won't see very commonly, you know, spina bifida, and you're supporting the baby in that. Here's a brachial plexus injury. You'll see that sometimes. It can turn into this look, Erb's palsy, waiter's tip position. Just support, get good circulation in the area. Sometimes you'll see club foot, and these babies always need surgery, and support them before and after. This is a red flag case. He's 1.
What's this, monkey? Oh, he cooted.
He should be able to hold himself up into crawling at least. He melts into the floor. From the side? He can't press.
You want me to also send you videos because I have like a ton from the side, from the top, from.
Third, baby.
He just like crumbles.
Yeah, he crumbles. We'll figure out if it's, first of all, coming from the base and how locked up his SI joints are. Yeah. Yeah.
Sweet,
and also,
sweet little boy. He slips through my hands. A baby should resist.
Try to put him on his feet.
Okay.
A baby,
He'll just like
right here. A baby should resist and pinch their arms in so they don't fall. But I have to squeeze his thorax so he doesn't
but
fall.
He goes in jolly jumper and does jump.
Yeah.
And then I'll take him out.
Yeah. He's doing all that.
I'll take him out of it and just like put his feet on the floor to try to get him to push.
So at 1 year old, he should be doing a lot more than that. I'll get back to that case in a minute. This is what plagiocephaly looks like, flattening on one side or the other. When the flattening is straight up the back, it's called brachycephaly. Some cases are pretty severe, and you might think, oh gosh, are some of the sutures fused? A condition called craniosynostosis. When I wasn't very experienced, I kind of panicked and thought a baby I was seeing had a fused suture because their head was so misshapen. And I don't think I did anything wrong by referring them to their doctor to have it double checked, but doctors can x-ray or ultrasound the sutures to make sure nothing's closing. But one little hint about being able to tell if it's plagiocephaly, regular flattening on one side or the other, or a fused suture. If you're not sure, just look up some Google pictures. But in plagiocephaly, the flattening side, the ear will go forward because everything's being pushed forward up through the frontal bone as well, right? In craniosynostosis, the ear on the affected side is moving back. It looks like it's posterior to where it should be. So that's a little hint. But again, if you're not sure, just look at some pictures on Google. There's lots there. Just a picture of the squeeze out the vaginal canal. Babies look long in the head at the vertex there because that's the smallest part of the head. And just want to point this out. This little guy has overlap sutures. These are difficult to treat because you can't move the cranial plates. It's not our business to move the cranial plates. What you're trying to do is support the body and that whole dural membrane, right, all the way down to S2 to let the pressure inside push everything out and equalize everything on its own. And that's something that, I followed him through for 2 years, obviously spreading things out as we got to the end. I thought I'd throw something fun in here, but here's little twins, Leia and Zaya. And they both couldn't sleep. Mom brought them to me at, I think they're 9 months here. And they both hadn't really slept a night through yet at all. And she even had another little boy at home. So I did not know. I did not know like how she's managing. But they both were stuck in their dura right at the, I don't know if you can see my cursor, but right at the ethmoid nasal, like frontonasal area. And the first day I saw them, I can't believe I found it really that quickly. They both had the same restriction. One of them moved too much and I couldn't actually get it to release. And one of them, I did get it to release. I want to know if you can tell by looking at their forehead. I know there's a bit of shadow here from Zaya's top knot here. I know, it's not perfectly lit, but which one do you think I was successful in releasing? Because I actually told the mom, I said, I think this one's going to sleep tonight and this one still won't. I'm sorry, but I couldn't get to it today. Let's try again next week. Just take another look at the foreheads, like look at the tension in there. Is anyone brave enough to try to take a guess, like which one I got to release?
Zaya?
Yes.
Yeah.
Yes. Yes.
Yeah.
It's her eyes
relaxed.
Yes, her eyes literally moved apart and this scrunching alleviate. Look at the scrunch on little Leia here. Crazy. So yeah, mom came back and she was like, you were right. Zaya slept. Leia did not.
I have a quick question.
Oh yeah, go ahead. Hi, Kara. Nice
Hi. I was wondering what the difference on your courses is between the tethered oral tissue course and the intraoral treatment course.
Oh, good question. there is a little bit of overlap. The staging and the anatomy is kind of duplicated into the intraoral course to refresh people's memory, but there's a lot more detail about tethered tissues and what dentists do and lactation consultants do, and like it's just a little bit more comprehensive that way.
Okay.
You
If we were starting out to treat babies, like, would you recommend the intraoral course first?
No, because like I would recommend the TOTS course first because there's a 20-minute demo video of how I break down different things on how to treat on a baby. The model is an adult, but that's because I had to film it during COVID and we couldn't see anyone. And there's just more anatomy in the TOTS course plus.
Okay.
Plus, like, if you want to end up seeing more and more babies, to understand the role between dentists and you, lactation consultants and you, that's all in there. So it's okay. Kind of like very specific to that subject. I would think that that's a better place to start. And then intraoral after. But what you can start to do is at least you know a lot of the anatomy inside the mouth, what we're looking for. Whenever you see a baby, feel in their mouth at least once. Start getting your frame of reference and start knowing what to feel. Okay. Because the more you do that, the better you will get. Then when you get to the intraoral course, you'll know what I mean by, oh yeah, how she said the tongue stays bunched up in the back of the mouth and doesn't come under.
Okay.
That's like, you know what I mean? It's sort of, I know we want to rush into that, but it's probably better to separate it.
Okay.
Cool. Yeah.
Okay. Thank you.
Hey, you're welcome. Going back to that little boy. So that was during COVID and the family doctor wasn't really, he was just not experienced. He was a new doctor. And I said, I just think there's more going on here. I don't think it's that he has tight hips. I think he just seems low tone. So insist on seeing a pediatrician. And she did bring the baby to see a pediatrician, and the pediatrician didn't even pick the baby up or hold the baby. The pediatrician just said, he's just a big boy. He'll start crawling when he's stronger. But he had missed many, many milestones. He was almost 1 year old. There's a ton of things he should have been doing by then. I just did some research. I sent them to a place called Children's Center, which is near Brock University in St. Catharines, and they see everything baby or child related. And they have specialists there that found that he had spinal muscular atrophy, which if you've heard of SMA, then you know a little bit about it. But if you haven't, it can be, minor, moderate, or severe. And the determining factor is you have to start treating it with gene therapy before they turn 2. And now I believe in Ontario, I think it's already going through. I know it is in Alberta, but they're doing genetic testing on all babies for SMA as soon as they're born because of the time crunch. It is time sensitive. You have to start treating it soon because it's natural for some babies to miss certain milestones, motor skills, or be slower in some and quicker in others. So the only way to know that, if, like, to get that addressed soon is to know genetically at the start and get it done through a blood test. So interesting. So you see something weird, it's not normal, like, be that parent's cheerleader. Just keep trying to find different ways to get someone to listen. So if the pediatrician, like this pediatrician, blew them off, send them to a physio center. Like, get someone else on board. Just keep pushing, keep supporting. Okay. Okay. I hope you found it useful. If you have any questions, let me know. If you want to check out one of the courses, so Kara, if you wanted to like quickly see what's in tethered oral tissues and then what's in intraoral course, we can book an appointment. Anyone, just contact me. We'll book a 15-minute slot where you can literally like click everything open. Don't start watching everything. You'll eat up your time, but click it open, see what's there. And then click, go in the other one, click it open and see what's there and see if it meets your needs. The birth one, anyone can explore really any course because you want to know what you're getting. In January, emails will go out to people if they want to take Dr. Evans's course that we do. It's online material that he has, courses like mine, but they're in his website. We designate parts of it to watch, and then we have a monthly Zoom over a 10-month span. It's a learning, but it's supported too. But some people don't want to do that. Some people just want to, you know, like, I'm going to dive in into this course online when I have time and like work this out. And maybe I'll do that later. You can do that too. So just letting you know the options. So thank you for joining me. If you want to share any comments or questions, or I take constructive criticism, please send it along. I'd love to tweak anything that anyone thinks needs tweaking. Bye.